Hello, everyone. Welcome to Chapter 5 of Healthcare Delivery in the United States, Population Health. Don Berwick is the founder of the Institute of Healthcare Improvement. And at one presentation, I once heard him say that healthcare is a weak tool. It's nearly impotent if we want real vitality in our populations. Indeed, healthcare is really just one of many factors that contribute to health, physical and mental health. And here are several others: education and income, genetics, behaviors, environmental exposures. And these factors contribute to the risk of individuals becoming ill, injured, or dying early. And they also influence the effectiveness of healthcare for specific groups. The population health model is fairly new, and the goal is to explain and intervene in these large-scale factors that we just discussed. A population health approach looks for systematic patterns of distributions, sometimes called upstream causes for health and wellness. So, for example, when a patient visits the emergency room, there are many reasons why that individual arrived at the emergency room. So population health experts want to understand why that happens for that individual and many, many others in the same group. Here are the main categories for these determinants of health: social and economic environment, physical environment, genetics and epigenetics, medical care, including prevention, treatment, and disease management, health-related behaviors, and then reverse causality. So healthcare is primarily addressing numbers 4 and 5 on this list: medical care and health-related behaviors. Although there are some clinics that do include resources for housing, employment, education. I once worked in one clinic that placed law students who could help patients complete applications for housing, as well as other minor legal issues. Reverse causality that you see here at the end of the list, this describes the event where an association between an exposure and an outcome is not due to direct causality from exposure to outcome, but rather because the defined outcome actually results in a change in the defined exposure. So for example, a study may find an association between recreational drugs, the exposure, and then poor mental well-being, the outcome, and thus conclude that using drugs is likely to impair well-being. A reverse causality explanation could be that people with poor mental health well-being are more likely to use recreational drugs as a means of escaping their situation. So thus, reverse causality provides a new perspective on barriers to health and well-being, and it's an important perspective to have. This figure here shows relative impact of various determinants of health. It assumes that broad factors like policies and living, working conditions have greater impact than individual health behaviors, which you can see on the left side. So as an example, think of the improvements in living and working conditions, public sanitation over the past centuries. So for example, the control of infectious diseases that resulted from clean water and improved sanitation, that led to controlling things like typhoid and cholera that were very dangerous and led to the loss of millions of lives. And so by reducing the risk to those infections, public health improved dramatically over the last couple of centuries. And so that's why there is this emphasis within population health on those large-scale efforts. Now compare the population health model with the medical model, which focuses on individuals. It explores pathophysiology. It takes a reductionist model. And what that means is that they're taking something that's complex and they're trying to reduce it to its smallest level so that they can understand it. It attempts to find the silver bullet that will stop or reverse those mechanisms and thus cure or prevent progression of the current medical problem. In other words, it's kind of like a watchmaker who opens up the watch to see how do all the gears, how do all the mechanics work together to make the watch work. The medical model also frames risk factors as working through disease-specific pathways. It analyzes risk factors as if they were independent in statistical modeling. And it considers how biological systems within the individual interact. So the medical model usually does not take into consideration other factors outside of that. From the medical model perspective, healthcare is generally reactive. We are responding to disease and abnormality. Healthcare has traditionally been delivered in acute episodes using the medical model as well. So less value is placed on health promotion and prevention. And then last, Americans' chances for living long and healthy lives are not improving despite ever greater US spending on healthcare. And so the conclusion here is that the medical model has contributed to a system that is great for acute care, but maybe not a good return on investment. Here, this figure shows again that the amount of healthcare spending in the US does not commensurate with an increase in life expectancy. You can see the USA is on the right-hand side, very far to the right for the x-axis, health spending per capita, but that investment is not giving us the kind of life expectancy that other countries have. Here is a case example comparing the medical and population health models. So under the medical model, and this is looking at obesity specifically. So under the medical model, we assess family history, diet, activity history. We collect samples for laboratory tests. And our interventions are to refer to a nutritionist, prescribe diet and exercise, maybe even bariatric surgery. From a population health model, the approach to obesity would be different. We would focus on obesity as an epidemic. We would look at risk factors like race and income. We would look at reasons for why a patient is maybe not complying with a treatment plan. We would look at zoning law changes and also menu labeling. We would work with the food industry to provide healthier options, and then also look at what kind of education policies could encourage healthy food choices. In some ways, the population health model is very similar to a public health model. The population health model focuses on different causes of obesity, higher density of fast food restaurants in low-income neighborhoods, vending machines, subsidized school lunches, a decrease in physical education, fewer people walking, fewer safe places to play or walk, lack of grocery stores with healthy food options, and marketing as well. So notice how these causes are broad and more related to those high-level social and environmental factors. Here's another case example. This is for tobacco. So from the medical model, we focus on specific individuals who chew or use tobacco. We look at behavior change. That could be cessation counseling, nicotine replacement options. From a population health model, we're looking at what is influencing the use of tobacco. So certainly tobacco production, advertising, distribution, patterns of use. And then we look at large-scale interventions like smoke-free laws, tobacco taxes, and the regulation of advertising and marketing. So let me pause here and say that both models are valuable, but also have limitations. The medical model has led to incredible advancements in pharmaceuticals and also behavioral medicine. The population health model is now guiding policymakers to consider larger influences. And this model may seem logical to us today, but it was not widely understood or used even just 3 decades ago. Some of you may remember the lawsuits against the tobacco companies in the 1990s. So in the mid-1990s, here in the United States, more than 40 states commenced litigation against the tobacco industry, seeking monetary, equitable, and injunctive relief under various consumer protection and antitrust laws. And the states alleged a wide range of deceptive and fraudulent practices by the tobacco companies over decades of sales. So these states weren't just blaming individuals for their use of tobacco. They were looking at tobacco production and advertising and distribution. The medical model is an important tool using research to understand biological and chemical mechanisms related to health. Consequently, the population health model is sometimes seen as less rigorous than the medical model. However, that stereotype is likely due to misinformation and limited exposure to high quality population level studies. Let me mention here a landmark study that changed the future of healthcare research. This is the Whitehall study. So the Whitehall study was of British civil servants that began in 1967, and it showed a steep inverse association between social class and mortality from a wide range of diseases. In other words, the lower the employment level of these civil servants, the higher the mortality rate. And so this is what came to be known as a dose response effect. And this was important because these were full-time jobs with benefits, and they were part of the middle class. And yet there was this clear health disparity that existed between these discrete employment levels. So later in the 1980s and 1990s, there was strong interest in what are known as neighborhood or area effects on health. And these studies showed that depending on where we live, our health may be adversely affected by neighborhood characteristics such as poor air and water quality, being close to hazardous substances, and living in substandard housing, and also having a lack of access to nutritious foods and safe places to exercise or play. The results of these important studies show that there is predictive power in these factors on life expectancy, like income, education, race and racial discrimination, and gender. Remember, this evidence was really not available during the first half of the 20th century. This figure comes from an important study by the Robert Wood Johnson Foundation, and it's called the Commission to Build a Healthier America. So this commission issued 10 cross-cutting recommendations for improving the nation's health. And according to the commission, how long and how well Americans live depend more on where we live, learn, where we work and play, rather than on medical care, and which accounts for only an estimated 10 to 15% of preventable early deaths. So this figure shows how education and race and ethnicity contribute to significant health disparities. You can see how college graduates, which are the light gray and the, well, college graduates are the light gray, some college is the dark gray. You can see how these individuals are more likely to enjoy better health compared to other education groups, like those that did not graduate from high school or only have a high school graduate degree. Here is another figure from the same Robert Wood Johnson report. This shows the influence of health behaviors by education group. Notice how the influence of health behaviors increases as education levels also increase. This suggests that health behaviors are not as influential as other factors for people with less than high school education. So remember that quote from Don Berwick that I shared at the beginning, where he said that healthcare is kind of a weak tool and that we need something that's stronger for improving the vitality of populations. So here we see more of that. During the 20th century, medical care explained only 5 of the 30-year increase in life expectancy. Between 1950 and 1990, new therapies for infectious diseases and heart disease were developed, but medical care accounted for only 3 of the 7 years of life expectancy increase. Medical care can be responsible for increasing mortality rates, and health behaviors are considered major determinants of health in both the medical and population health models. The annual county health rankings provide a snapshot of how health is influenced by where we live, learn, work, and play. And they provide a starting point for change in communities. These rankings are part of a program from the University of Wisconsin Population Health Institute. So these reports rank the overall health of every county within each of the 50 states. They report the contribution of multiple determinants of health. And the health outcomes are viewed as the result of a combined set of factors. And rankings demonstrated dramatic variation between one county and another. So the bottom line message is that where people live matters to their health. And so these rankings provide further evidence that environmental factors have significant influence on health outcomes. This figure shows the county health rankings model of population health, and it illustrates the many factors that influence health. So starting at the top, you can see programs and policies that have a direct influence on health factors. The main question for health factors, which you can see right in the middle, is what are the opportunities for community members to be healthy in the future? You can see the answer to this is broken down by health behaviors, clinical care. I'm looking at the second column right now. So health behaviors, clinical care, social and economic factors, and then physical environment. And then you can see examples of each factor as well. So notice that clinical care contributes just 20% compared to the other factors. And so once again, there is this pattern that clinical care really is just a small piece of the pie here. Let's circle back to this idea of what is the best return on investments. The US is a wealthy country, but the population health model raises the question, are we spending the money on the right places? Education and community level prevention initiatives could be additional places for more investment. The 2010 Affordable Care Act generated several changes, including increased collaboration by hospitals with public health community partners, the health dividend, prevention and public health fund, accountable care organizations, medical waivers, and innovation grants. In addition, the healthcare sector is paying more attention to social determinants of health. The integrated care models that are important for students in this program to know offer a strategy for combining our health system with other social service systems like housing, education, and employment. So the data is showing that population health approaches are important, and now we have new policies and new initiatives that show that the healthcare industry is starting to take a population health approach. And that is the end of this lecture. Thank you for watching.